Hello, thank you for your patience. Welcome to the ESIP Job Planning Toolkit webinar presented by Dr. Jyothi Nippani, Associate Medical Director from South Warwickshire Foundation Trust. First, we have just a few simple housekeeping points. This website is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right hand side of your screen. Alternatively, you can write your question in the questions section on the panel. During the Q&A sections, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to Dr. Nippani. Thank you.
Hello. Hello everybody and good afternoon. I hope you can listen. I hope I'm clear to everybody here. I'm Jyothi Nippani, as Paula just introduced me. I'm a consultant from South Warwickshire Foundation Trust. I'm also an Associate Medical Director for the Emergency Division in the Trust and have been in this role for just over 5 years. Before I start, if I can give you a little bit of a context as to how my journey into developing this job planning started. Way back in 2011, our trust collaborated with the Health Foundation UK and took part in an acute flow project. This was aimed at improving the efficiency and quality of emergency care in the hospital. As soon as we started work on the project, it was very obvious that in order to maximize the efficiency, improve the quality, and provide the best patient experience, we had to concentrate on 3 key high-impact areas. The first one was senior decision-making at the front door. The second was timely access to pathology and diagnostics, not just at the beginning of the patient journey, but throughout the patient journey. And the last was timely access to specialty advice, again, not just at the front door, but throughout the inpatient stay of the hospital, which included daily specialty board rounds and ward rounds. And this last reason was what led to an extensive redesigning of the job planning process. Previously in the trust, especially within the medical division, the job plans of the physicians did not lend itself to delivering the sort of needs that we had for the acute flow project. Most physicians had 1 or 2 ward rounds scheduled in their job plan every week, sometimes in the afternoons, and if the consultant was away, decisions were left to junior teams. There were many consultants popping into the wards every day at their own convenient times, and this interrupted the nursing teams on several occasions. Each consultant looked after only a proportion of the patients and with their own junior team, but the nursing team was common to all. Patients with very similar complaints were managed very differently, depending on which consultant they were under, and the nurses and the junior doctors were often confused. Patients on adjacent beds with similar problems were being managed differently. As we all know, the junior team was always split according to the consultants, and there was little scope for cross-covering too. In addition to that, specialty referrals was a long drawn process and took anything up to a week due to the system issues and the consultant working patterns. So our front-end teams did not get the input that they needed from those specialties. So what we wanted was consultant job plans to fit in with the needs of the patient flow, and this led to the redesigning of the job plans. So the redesigned job plans allow for specialist access to the ED and AMU on a timely basis. So as and when the ED consultants and AMU consultants in the front door need specialist advice and help, they are available. The job plan also allows for daily board rounds and ward rounds with one ward, single ward team. We also wanted continuity of care for inpatients, so we developed a consultant of the week model, and we felt that the consultant of the week model was needed in a few of the medical specialties. There was already consultant of the week model in the surgical specialties, obs and gynae and pediatrics and orthopedics. But within medicine also, for 4 major specialties, we felt there was a need for consultant of the week, and that's what we did. Within the consultant of the week, we had to allow enough time to allow for the flexibility to accommodate for the variable emergency workload. So sometimes inpatients, the new admissions on the inpatients can be 5 or it can be up to 8 or 12 some days, depending on how many discharges are there. And we wanted to allow for that flexibility within the job plan. Now, today's work today is the slogan on our inpatient medical wards and on the surgical wards. So we wanted to make sure that the job plan allowed for that to happen. And because we were carving off a significant proportion of the job plan of the consultants for emergency work, we wanted to make sure that elective activity was also accommodated within the job plan, so that the RTT, which was the main income generating bit for the trust, could be delivered too. And this is what led to the concept of annualized job plans. A little bit about our trust. We are a foundation trust from 2010. Warwick Hospital here in the middle is our main acute site. We acquired the Warwickshire Community Services in 2011. We have a turnaround of around 250 million and employ 4,200 staff. The population of the whole of Warwickshire is around 500,000, and within that, the South Warwickshire population is 270,000. And like in most hospitals and most as we see nationally, growing elderly population is one of our features too. We have 150 consultants, and within the emergency division we have a range of medical and surgical specialties, including obs and gynae and pediatrics. So what I will cover in the next few slides is my personal journey as to how I approached it, and I'll use an example with a significant amount of detail, and I'll just end up with one slide on the challenges that I faced through my journey. Now, the principles of doing the job plan. Previously, job plans were always done on a one-to-one basis with a consultant sitting with a CD or maybe a manager. No one really thought about whether the job plans of the consultants in the department all put together fulfill the needs of the department. If there was extra work, the managers went about requesting each consultant to do extra clinics, often at premium rates, and if it was over the weekends, it was a much higher rate, often up to 8 PAs per session, which was completely ridiculous. Now, there was a perverse incentive, therefore, to cancel scheduled activity and do these extra lists. Although most consultants ended up doing all the work needed at the end of the year and achieve the RTT, which is the referral to treatment, some of the consultants did a significant amount of this work at premium pay. This was felt unfair to the rest of the team who managed to do this within their job plan. So I have always approached job planning as a department and not individually. So the individual bit comes much later on in the job plan, where we are refining it, refining some special details. So the job planning is transparent to the whole department. We all sit around a table with the manager and all the consultants, as we can see in the little diagram next door. We assume that each consultant will give 42 weeks worth of their time out of the whole year if they are a full-time consultant, because we take 10 weeks off for annual leave and study leave, bank holidays, professional leave, and whatever. We always have the previous year's activity data and the next year's forecast of the contract negotiations ready. Not always happens, but at least we have a fair idea of how much we need to include within the job plans. SPA activity is separate, and this can often be individual if the consultants are doing leadership roles. Now, the idea at this meeting, and we have 2 or 3 meetings scheduled if we are doing job plans in a month, and these dates are given out in advance so that we all make sure everyone attends these meetings. And the idea is to understand very clearly what is the total emergency and elective workload within the department, and then balance it with the total PAs within the department. And often we find that we may have to pay the consultants a little bit above the 10 PAs in terms of DCC or SPA to ensure that the entire workload is met by the department. Now, again, the principles of emergency activity, and the emergency activity, which I said is normally means consultant of the week, including the weekends and the out of hours unscheduled presence. So this activity is shared equally amongst all the consultants unless there's prior agreement that someone does less or more. Then there's a rolling rota for 52 weeks. So if there are 5 consultants in a department, then they do a 1 in 5 of consultant of the week. So 10 weeks in a year goes off in the delivery of the consultant of the week. If it is 1 in 6, accordingly, it's less number of weeks, but that's how we calculate. No annual leave or study leave is taken during the consultant of the week time, and elective sessions are cancelled during this period. And there is very clear agreed guidance on the responsibilities of the consultant during the consultant of the week. Example, in some specialties they may include hot clinics, cath labs, GP referrals. It depends on what we think is reasonable to be fitted into this consultant of the week. Apart from the ones I said, where they need to be available for the front door and see all the referrals throughout the hospital as today's work today. Now, the elective activity, we look at the number of sessions needed to get through this activity in a year, and this elective activity is delivered in the non-emergency, non-annual leave and study leave weeks. So if we use the example before, if there are 5 consultants in a department and they're spending 10 weeks in a year doing consultant of the week, then you have another 10 weeks taken off for annual leave and study leave. So they only have 32 weeks in a year where they can deliver this elective activity. Sessions are cancelled when they're on leave, and it's really important that the sessions are not given away to other specialties, because your other colleagues will move into these sessions and they can deliver the same sessions in a flexible way. So as you can see, there's a need for the rest of the consultants to have a flexible timetable. There's a fixed timetable where you have a regular session every week, and then you also need the flexibility to fit into other colleagues' sessions to accommodate your total sessions for the year. This is what leads to annualization, so that at the end of the year, by the end of the year, you get through the total number of sessions that you've been contracted for. The beauty is that no additional payment is needed for these sessions until the contracted sessions are delivered by all the consultants. I'm using the example in OBS and Gynae. The first reason is because it's my specialty, and secondly, this is a specialty which has got clinics, theaters, and emergency work. So it could extend to both the principles of this could be extended to both medical and surgical specialties. So the emergency activity, starting with that. We do a consultant of the week, and when we do the consultant of the week, we cover between 8:30 in the morning to 5 o'clock in the evening during the weekdays, and on the right hand side of the screen is the weekend cover. So it's 8.5 hours a day, and over 5 days, that is 42.5 hours, which is divided by 4 is 10.6 PAs for weekday emergency cover. Over the weekends, we do 1 PA on a Saturday and 1 PA on a Sunday, which is 3 hours. And so that's 2 PAs. And one thing to remember is if you're doing scheduled activity over the weekend, there is no travel allowance. It's only for the out of hours unscheduled presence over the weekend or out of hours that travel allowance is paid for. So if you put the two together, the weekdays and the week cover, so it is 10.6 and the plus 2, which is 12.6 PAs per week. So sorry, 10.6 and 2, which is 12.6 PAs per week. Because we do a 1 in 8 week rota, we do the consultant of the week 6.5 times in a year. So multiplied by 6.5 gives rise to 81.5 PAs per year, rounding it off to 82 PAs per year, and divided by 42 because you take 10 weeks off for annual leave and study leave, and that gives you a 1.9 PA per week with prospective cover for the emergency activity, which is scheduled activity. To that, you add the out of hours payment, which is the unpredictable on-site presence. This can vary from specialty to specialty and hospital to hospital, depending on how intense your out-of-site presence is. Now, coming to elective activity and clinics first. Again, the principle is, as I said, we look at the total numbers of patients seen the last year as a starting figure. When you're doing job plans this way for the first time, this is how we did it. We looked at the total number of patients seen in the last 2 years actually and divided it by 2 just to get a better idea. We also add the backlog that was left at the end of the year so that you are covering covering the entire workload. To that, you add the DNA rate. To that, you add 5%, which you can say could be the growth if you think the the demand in the department is going to keep growing. Or you can keep 5% as a buffer just in case you have to cancel some clinics or theaters for non-availability because of sickness. You still are putting all those into the job plan. If you want, you could do that. So 5% for growth or as a buffer. This gives the total demand of the clinic need in the department. Next, we standardize the clinic templates, and we have agreed to have 4-hour clinics in our specialty. Some may want to do shorter clinics, but a 4-hour clinic will attract 1 PA, whereas if somebody is doing short clinics, example 3 hours, it attracts only 0.75 PAs. So at the end of the day, if we are all being paid equal amount of money for clinics, then those doing shorter clinics will need to do more number of clinics to earn the same amount of PA value as the rest of their colleagues. I'm using this example. So in our specialty, we needed 3,000 new patient slots, including 2-week referrals within the department. This was including the DNA rate and the 5% growth or buffer. We as a department agreed to have 20 minutes for a new patient slot. So we have 12 patients per clinic in a 4-hour clinic. So as a department, we needed 250 clinics in the whole year. And we have 8 consultants to deliver this. So each consultant needed to do around 32 clinics per year. Now 32 clinics per year covering for annual leave and study leave divided by 42 is 0.76 PAs per week. So each consultant also, if you look at it differently, also sees around 32 into 12, where in each clinic 384 new patients per year. Now there may be specialties where consultants are seeing within the clinic template they have news and follow-up mixed, but we can work out whatever the need for the follow-ups is and what is the time slot that one is allocating for the follow-up session, patients. Again, the follow-ups are not being delivered by the consultant, but are being delivered in the consultant's name. It does not come under consultant activity. They may have responsibility for the follow-up, but if they're not actually delivering the follow-ups themselves, it is not calculated within the consultant activity. Elective activity covering theatre. Again, we looked at the total number of sessions needed per year within the department to maintain the RTT. Again, when we started, we used previous year's figures, and we included all the extra sessions that we ever had to do, paid, and the weekends, whatever we had to do to deliver the RTT. And then we calculated the PA per session, and we included the pre-op time within the theatre time. For example, if your theatre session was 3.5 hours, then we included half an hour and as the pre-op time, where the consultant goes around checking the consents, making sure the VTs are present and the pre-op investigations are all normal. So the theatre session, the actual operating time may be 3.5 hours, but the theatre session is 4 hours. You could tailor it according to your needs. You may want to make the operating time 4 hours and have additional half an hour for the pre-op time. Depends on how we want to run it. And then you allocate the theatre sessions in proportion to the need and subspecialization. For example, within our specialty, we needed each consultant to deliver anything between 45 to 60 sessions per year. The oncology leads, those who were doing cancer surgery, obviously needed more sessions in their timetable, so they were contracted for more sessions. So there was a fixed timetable where there was a theatre session every week, and then there were flexible sessions too, which were the sessions which the consultant colleagues had to cancel when they were doing their annual leave or study leave or were in the hot weeks. So we never gave away our departmental sessions to anyone else, so any other department. We contained it within the department, and the consultants were very flexible and delivered these sessions in a flexible way. Now, admin sessions, again, this varies from specialty to specialty, but it is definitely proportional to the sessions which generate admin. Not all sessions generate admin, especially the emergency activities. I think generates lesser admin than the elective activity. And within the elective activity, some clinics generate much more activity than other clinics. So it depends, and again, this has to be agreed within the department. And they should also have an impact on the new to follow-up ratio of the clinic. So the specialties and the consultants who are being paid more admin, this should be reflected in the new to follow-up ratio. So those who get paid more admin, we expect that the new to follow-up ratio in the clinics are reduced, so that they should have very minimal need for minimal follow-up. For example, if you're doing 100 clinics a year and you allocate 1 hour of admin per clinic, that's 100 hours per year. That equals 25 PAs per year, which calculated for allowed for annual leave and study leave equates to 31 PAs per year, and that is 0.6 PAs per week. So someone who does 100 clinics per year being paid an hour of admin per clinic would get 0.6 PAs per week of admin. Now, Sorry. Ward rounds. Within medicine, the medical ward rounds are really important. They take a long time, and this covers most of the emergency work, and this is the inpatient activity. And as I said, specialties which have consultant of the week, we have allocated up to 10 PAs per week. Not all specialties need consultant of the week. They may just need an hour or two every morning to do a board round. Some wards don't need that much of consultant input. But those specialties who have consultant of the week and who we are paying 10 PAs per week, there's a lot of expectation within that time to be delivered. So this is sort of the activity that the consultant has to undertake within those 10 PAs. They have to do a daily board round and a ward round and justify every inpatient's stay. They have to, what we say, do all the pulls from the acute medical unit and a accident and emergency. So first thing in the morning, they go to the acute medical unit and ED and identify the patients that need to be brought to the ward, or often they discharge patients from there if that can happen too. So after the day board round and the ward round, they see the referrals from across the whole hospital, from the surgical wards and orthopedic wards, wherever they are called. They answer all the GP queries. We also have a system of e-referrals which come through the GPs, and the e-referrals for that day are seen by the consultant of the week. They also see any urgent GP referrals that are sent that particular day to the specialty. All the admin from the emergency work, whatever there is absorbed within the consultant of the week. Most importantly, they provide leadership and support to the team, which includes the medical nurse practitioners. They also have an evening mop-up ward round, and the whole team meets to ensure that today's work has been done today. So everything that was agreed in the morning board round or ward round has actually happened. So if a CT was requested, that has been done or not done, what was the outcome, and has it changed the management. And they also decide which are the patients going home tomorrow, make sure that TTOs are done. So it's a sort of mop-up meeting at around 4 o'clock, and this is encouraged too. So all this is done within the 10 PAs per week in those specialties. Now SPAs, all I would say is just to beware of double counting. So we need to pay for work delivered outside the DCC. DCC is direct clinical care, to avoid double counting. And this can easily be done. As I said, emergency cover varies. Sometimes it's very busy and you've got no time to do anything else, but sometimes it is not that busy and you can do a lot of teaching and admin in that. It's absolutely fine, and we encourage people to do that, but just make sure that if you're paying them for teaching, they're actually doing teaching outside these 10 PAs. So there should be some dedicated teaching sessions, like a tutorial or something that you're paying for. The teaching on the board round clinics is very good and it should be encouraged, but that can't be counted as teaching SPAs. And similarly with the admin. Those who are being paid leadership roles, will have, if the sessions are cancelled to deliver those leadership roles, they have to be paid back to the trust as well. An example is if somebody is a college tutor and they're being paid a PA a week to deliver that, and they have had to cancel a session to attend a deanery meeting, they have to pay us back that session. So we make sure that that's done. This is another thing we put in, one mandatory SPA. As a department, we all make sure that once in a month we have a departmental meeting, and this is a mandatory SPA for all of us. We have it on different days of the week, so that on a rolling basis, different days, different sessions are cancelled, so that one person is not affected all the time. All sessions are cancelled for the departmental meeting once a month. And again, these sessions have to be paid back because these are paid SPA sessions. Non-attendance at these meetings is taken quite seriously, and if there's no good reason why you are not able to attend a departmental meeting, it's taken as annual leave, forced annual leave. On the surgical side, the ward rounds are slightly more different. The pre-op time is included within the theatre session. As I mentioned, it could be 4 hours, 4.5 hours. The post-op ward rounds again depends on the sort of work that's being done. Day case lists need a short ward round post after the theatre session, and you see the patients post-operatively and nobody stays in. Whereas if you're doing major cases and you've got inpatients to do ward rounds on, then they need to be paid differently. Usually it's 30 minutes per day for inpatient ward round and around 30 minutes per session for day case lists following a list, and that could be included within the PA for the sessions if that's what the consultant undertakes mostly. And again, when you're calculating these per week, make sure that you take out the weeks that they're on call, because they'll be doing a ward round, but they're being paid for the consultant of the week in the on-call weeks. The advantages of annualization is that you can be confident that the RTT can be met within the job plan. One does not need to pay for extra activity unless we got the data wrong, and the very first time we did it, we did get the data wrong, and we had to change it afterwards. So we don't need to pay for extra activity until all the contracted sessions are delivered. And the other real beauty of this is it does not matter when the consultants take annual leave or study leave, etc., as the onus is on the consultant to get the sessions done by the end of the year. The disadvantages are we need a regular fixed timetable and the great ability to be flexible, especially with theatre sessions which are quite like gold dust. The journal manager has a job, a big job, has to be absolutely on ball with what is being expected in the department and what is of a consultant and what is the actual activity performed every month. So in our departmental meetings, which are very, very important every month, our GM actually gives us a figure of, for each consultant, what was expected in the last month and what was delivered. And I'll show you a little bit about that later on. And the other disadvantage is once the activity is delivered, the consultants can, in theory, be off. Eventually, what it looks like, I've just given you an example, and this is not the actual one, it's just an example, so I can be very sure that I'm not disclosing anyone's personal job plans here. These are our 8 consultants, and this is about what it looks like for each one, and you can see there is varying amount of PAs given for this is gynae patients. Some do specialist clinics, though they get paid extra. Those who take part in the MDT get paid for that. Ward rounds, again, depending on what they're doing, it varies depending on how much they're contributing to. Admin also varies, and eventually you can see what the eventual PAs are. And again, this is reviewed every month, every year, and we change it. As you can see, I've kept the SPAs quite similar for all, and all the leadership roles within the department are within that. But that may not be what you would want to do as a specialty, and it may be less or more depending on how you want to distribute it. And individually, when it comes down to doing individual job plans, this is the sort of letter which goes out to each individual. And as you can see, you can say this is my job plan. For example, this is what I get paid to do the emergency activity. I have to deliver antenatal clinics which deliver that much of PA value. I have to deliver 45 theatre sessions in a year, and it's up to me to deliver them within the 42 weeks that I have. And in my annual leave, taking my annual leave out as well. I have to deliver 35 4-hour gynae clinics in a year and 35 4-hour postmenopausal bleeding clinics. So this is up to me. So this is what I have to deliver in a year. And how do we monitor? And this, as I said, is the most important thing. In our departmental meeting that we have every month, this is what gets displayed to us in front of all of, in public view of within the department. I've just covered up the names, but these are the 8 consultants. As you can see, the blue one is the planned activity and the red one is the actual activity. So some consultants have delivered a little bit less than the actual activity, and some here have delivered a bit more. So this is theatres. So the first time this was put up on the board, I was waiting to see what the reaction would be, and one of the consultants who had actually delivered less than the planned immediately turned around to the manager and said, "Can I have another session, please? I've got some time next week, and I'll make sure I'm equal to the rest." So that was a very positive, a positive attitude. And this is a clinic activity. Again, the blue one is the planned and the red one is the actual. So without this, you don't have a yardstick to go by to see whether you are delivering your RTT correctly or not. And every month this is added up, and you can see the total activity every monthly departmental meeting. This activity is added up, and we can see as a department if we are delivering the contracted activity or not. One slide, this is the last slide on challenges. People don't like change. This is too prescriptive for some. They don't like the flexibility, and basically they don't like to be flexible, and they would rather have a fixed job plan and know what they're doing every week. So this is something that they may have to come around to and agreeing to it. And like with any job planning, there's a fear that, oh my God, maybe in this round, something will be introduced and my pay will be reduced, and people don't like a pay cut. We have specialties who say, oh, we are hard to recruit, so for the same amount of work we need to pay us more, and I'm sorry, but that's not how it works. We work hardest in the trust, and again, this consultant contract has got nothing to do with the intensity of work. It's a time-based contract, so it's okay. My sympathies for those who actually work very hard within the 4 hours, and some may not be working very hard in the 4 hours that they are working, but that's the way life is. Once job plans are done, specialties, they talk to each other. They say, oh, I got paid so much for our admin. Why are you getting paid so much? But again, there's a lot of work which needs to go into planning how much admin is being paid for, how much SPA is being paid for, because people will talk and they will compare. So we just need to be very, very fair, and we need to have an answer, a robust answer for everything. Some individuals get really pedantic about very, very minute detail, and this is where it gets down to one-to-one job planning. There are threats, and I've had loads of them from LNC, BMA, and other organizations, but this is all written up within the consultant job plan, so there's really no need to worry. And with these single individuals who can be very pedantic, as a department, as a whole, there can be delays in ultimately signing off the job plans. And so these were some of the challenges, but we've been doing that now for this sort of job planning in most specialties in our division for the last 3 years. And if anything, more and more people are asking for this rather than not wanting this sort of job planning. So I feel there is a place for this. Which actually allows for the emergency activity to have its flow, which we need. And the list goes on, but yeah, I'm sure I'll be facing new ones as we go along. So there we are. So thank you for listening, and any questions, please? Thank you, Paula. Hello.
Hello.
Hi, hello.
Hello. Thank you, Jyothi. That was great. If anybody's got any questions, like I said before, alternatively, well, you could write your question in the question section panel, or you can raise your hand and then I can unmute you to ask your question to Jyothi. So if we just give everybody a couple of minutes to do that, that'd be great. I don't know if you want to pop your email on your slide there, Jyothi, if you're happy for people to email you, or it can, or they could always go through the ESIP mailbox and I can forward them.
So I could end the show and give my email, put my email there, not a problem.
Okay, lovely. We've got a question from David Donegan, so I'll meet you in a second, David, and then you can ask your question.
Yeah, there we go.
David's actually typed in a question. He's typed in, "Can we get a copy of the slides?" Yes, that'd be no problem. The webinar is also being recorded and will be uploaded to the ESIP website, just to let everybody know. Okay, we've got another question from Aram Saili. Question is leadership / management role counted as SPA or else?
It's totally dependent. It varies from specialty to specialty. In some specialties, you have lots of medical students and junior doctors, and so your 2.5 SPAs are taken up for the teaching. So if all your SPAs are used up for teaching purposes, then you may have to go beyond your 2.5 SPAs for the leadership roles. But if there's spare capacity within the 2.5 SPAs, certainly we'd like to keep it within the 2.5.
Okay, thank you. That's great. Okay, just give it a minute or so just to see if anybody else would like to ask anything. Okay, it doesn't look like there's anything else coming up at the moment, Jyothi. Is there anything you'd like to add before I wrap things up?
As I said, my email address is there, and I'm totally happy to take email queries or talk to them on my phone number. I can even, shall I put my phone number down as well, and I can they can call me as well, not a problem.
So, yeah, if you're happy for that.
Yeah, I'll put my phone number down there.
Okay.
Okay, that's it.
Okay, great. That's lovely. Okay, just to just mention again, if anybody has got any email queries, they could either email Jyothi or email the ESIP mailbox at esipinfo@nhselect.org.uk, and then I'll ensure that the question is sent to Jyothi. Just to say thank you for taking the time out to provide us with this presentation, Jyothi. It's very much appreciated. And also just a quick reminder that the recording of the webinar will be available on the ESIP website shortly. And just to say goodbye from all of us and thank you for joining us today.
Thank you, Paula. You're welcome.
Thank you. Goodbye, everybody.
Thank you. Bye-bye.